Adab, Namaskar. Good morning, everyone. I am Dr. Anilita Moluk-Shruti, working here as an Indoor Medical Officer, Department of ICU, Community-Based Medical College and Hospital, Bagladesh. I would like to welcome you all in today's clinical seminar. Today's topic is post-operative care and role of an anesthesiologist. It's a privilege to have our Honorable Chairperson, Dr. Mahmoud Masood Hassan Sir, Associate Professor, Department of Anesthesiologist, and Dr. Mahmoud and our resource person, Dr. Lipun Kanti Bhumik Sir, Associate Professor, Department of ICU. Now, I would like to invite our Honorable Chairperson and resource person to the dais. Thank you, sir. Now, I would like to invite our today's speaker, Dr. Tasnuba Mehtaz Abu, Indoor Medical Officer, Department of Anesthesiology, to have a take and deliver her speech on today's presentation. Thank you, everyone. Assalamu alaikum.
Honorable Director Sir, my respected teachers, my senior and junior colleagues, and beloved interns, good morning. Our today's seminar on post-operative care and role of an anesthesiologist. Here we discuss about the post-operative room environment and the complication that may arise during post-operative period and its management in short. I am requesting Dr. Tasnuba, the speaker of today's session, medical officer, Indoor Medical Officer, CBMCH, to start our session. Dr. Tasnuba.
Thank you, sir. Good morning. Assalamu alaikum. Honorable Chairperson, sir, Resource Person, sir, Honorable Director, sir, my respected teachers, my fabulous colleagues, and I am Dr. Tasnuba Mehtaz, Indoor Medical Officer, Department of Anesthesiology, Community-Based Medical College and Hospital. I am here to present our scheduled seminar, and my topic is post-anesthesia care, post-operative care and role of an anesthesiologist. Now I am going to present my presentation. Introduction. Recovery from anesthesia can range from complete recovery or patient may develop complicated to life-threatening condition. Must be managed by skilled medical and nursing personnel. An anesthesiologist plays a key role in optimizing safe recovery from anesthesia. Post-anesthesia or post-operative care. Definition. It is the specialized care given by the patient who have undergone anesthetic management by a team of well-trained professionals in a specially designed, equipped and designated area of the hospital. Purpose: to enable a successful and faster recovery of the patient, to reduce post-operative mortality and morbidity rate, to reduce the length of hospital stay of the patient after operation, to provide quality care service, to reduce hospital and patient cost. Post-anesthesia care unit. Definition. It is specially located, specially designed, specially staffed, specially equipped, specially designated area of hospital for a specific purpose. History of post-anesthesia care unit. Methods of anesthesia have been available for more than 160 years, but the post-anesthesia care unit has only become common for last 70 years. One can trace it to Lady of the Lamp. In 1920 and 1930, several post-anesthesia care units opened in US and abroad. In 1947, a study was released which showed that over an 11 years period, nearly half of the deaths that occurred during first 24 hours after surgery were preventable. In 1949, having a post-anesthesia care unit was considered a standard of care. Post-anesthesia care unit location should be located close to the operation theatre. Immediate access to X-ray, blood bank, blood gas and clinical labs. An open ward is optimal for patient observation and at least one isolation room for immunocompromised patient. Central nursing station must be there. Required good ventilation. Design of post-anesthesia care unit. Size ideal 1.5 post-anesthesia care unit bed for every operating room, 120 square feet per patient, minimum of 7 feet between two beds. Facilities: polar cot with side rails, piped oxygen, vacuum and air, multiple electrical outlets, large doors, good lighting, isolation for immunocompromised patients. This is an image of an ideal post-operative or post-anesthesia care unit. This is a small image of post-anesthesia care unit of community-based medical college and hospital. Post-anesthesia care unit staffing: one nurse to one patient for at least 15 minutes of recovery, then one nurse for two patients. The anesthesiologist is responsible for anesthetic remains management in the post-operative care unit. Adequate number of ancillary staff such as technician, ward boys and female attendants. Post-anesthesia care unit equipments: multiparametric monitors, automated BP, pulse oximetry, ECG, and intravenous support should be located at each bed. Area for carting, bedside supply storage, suction and oxygen flow meter at each bed. Immediately available emergency equipment, defibrillator, crash cart. This is an image of ideal post-anesthesia care unit equipment and staffing. Transport of patient from operation room to recovery room. Avoid hurried movement and rapid changes in posture. Avoid rough handling. Avoid exposure. Routine post-anesthesia care. Criteria for shifting patient from operation room to recovery room. Patient must be hemodynamically stable, clinical evaluation and complete recovery from neuromuscular blockage, maintenance of oxygen saturation and normothermia. Post-anesthesia care unit standards. Persistence vigilance of an anesthesiologist. All patients have received general anesthesia, regional anesthesia or monitored anesthesia care should receive post-anesthesia management. The patient should be transported to the post-anesthesia care unit by a member of anesthesia care team that is knowledgeable about the patient's condition. Upon arrival on the post-anesthesia care unit, patient should be re-evaluated and a verbal report should be provided to the nurse. Admission report. Pre-operative any significant history, intraoperative factors such as procedure, type of anesthesia, estimated blood loss, urine output, assessment and report of current status, post-operative instruction if any. Post-anesthesia care unit length of stay. It will vary depend upon several factors such as type of surgery, patient's response to the surgery and anesthesia, medical history. Average length of stay is 1 to 3 hours. It may be longer. Post-anesthesia care unit vigilations. It is limited due to safety and confidentiality of the patient, risk of infection, interruption to the workflow. Monitoring of the patient in post-operative care unit or post-anesthesia care unit. Monitor of the vital signs, blood pressure, pulse, volume, regularity and depth and nature of respiration, assessment of patient oxygen saturation, skin color, temperature. Monitoring the vital signs. Check the patient consciousness and ability of response to command. Maintain intake and output chart. Protect the airway by proper positioning of patient's head, by cleaning the airway, by oxygen therapy and prevent pharyngeal obstruction by oral or nasal tube. Maintain IV stability. Assessment of the surgical site for hemorrhage. If hypovolemia or hypovolemic shock, patient may be needed colloid or crystalloid solution, blood or blood product may be transfused. Keep the patient warm by using warmer blankets, warm lights, etc. Management of pain. This is the most important care given by the post-anesthesia care unit after surgery and management of pain. Administered opioid analgesic, epidural analgesia, NSAID, psychological support, etc. Here we summarize some commonly occurring, some common post-anesthesia or post-operative complication we faced in our post-anesthesia care unit. Nausea and vomiting, respiratory complication, airway obstruction, laryngospasm which is common in children, hypoxemia due to hypoventilation, post-intubational cough, which is also common in children. Circulatory complication, hypotension, hypertension, arrhythmia. Central nervous system complication, consciousness may not return, consciousness may depress due to sedative, excitement and confusion, pain, shivering, hemorrhage, metabolic, hypoglycemia, hyperglycemia. Others, headache, sore throat, hoarseness, muscle pain, oral trauma, dental injury, pulmonary embolism, fever, post-operative renal dysfunction, post-operative hepatic dysfunction. Here is a small discussion about commonly occurring post-anesthesia complication. Post-operative nausea and vomiting. Risk factor, female patient, patient with history of motion sickness, children aged more than 3 years old, hypotension, use of volatile anesthetic agent, opioid use, ENT squint or gynecological surgery, pain. Management, removal of the triggering factor. Using one or more of the selective 5-hydroxytryptamine receptor antagonist, metoclopramide, phenothiazine, dexamethasone, IV, dorperidol. Respiratory complication, airway obstruction may be due to tongue fallback, laryngospasm, secretion, foreign body, bronchospasm. Prevention, not to oversedate the patient. Complete reversal from neuromuscular blocking agents. Avoid excess suctioning and close monitoring of the patient. Hypoxia, risk factor, old age, obesity, prolonged surgical procedure, upper abdominal and thoracic surgery. Hypoxemia may occur due to hypoventilation caused by pain, respiratory center depression, inadequate reversal from neuromuscular blocking agents. Management of hypoxia, management of airway, oxygen inhalation, mechanical ventilation, intermittent positive pressure ventilation or non-invasive ventilation if necessary, treatment of the cause. Next, laryngeal spasm. This is common in children. Management, oxygen inhalation, jaw thrust maneuver. This is an image of head tilt, chin lift and jaw thrust maneuver. Positive pressure ventilation, low dose succinylcholine may be effective. Endotracheal intubation may needed. If not possible, tracheostomy may needed. Here is an image of tracheostomy tube in situ. Tracheostomy tube. Laryngeal edema. This is common in children. Bronchospasm. This is common in patient with history of bronchial asthma, history of hypertension, hypoxemia, hypercapnia, metabolic acidosis. Next, circulatory complication, hypotension caused by hypovolemia, residual effect of anesthetic drug, history of hypertension, hypoxemia, hypercapnia, metabolic acidosis. Management of hypotension, elevation of leg, intravenous fluid administration, if necessary transfusion of blood and blood products. Circulatory complication, hypertension, elevation of causes hoche elevation of legs, pain, bladder distension, history of hypertension. Management, mild to moderate elevation can be treated by intravenous beta blockers such as labetalol, esmolol, diuretic, ACI or calcium channel blockers, sublingual nifedipine. Marked hypertension should be treated with intravenous hydrolazine, nitroprusside, nitroglycerin. Arrhythmias, causes pre-existing cardiac disease, residual anesthetic agent, hypoxemia, hypercapnia, electrolyte imbalance, pain, myocardial infarction, vagal stimulation. Fibrillation, flutter and supraventricular tachycardia are treated by cardioversion and respective medication. Sinus tachycardia, causes are hypotension, shivering, hypoxemia, hypoglycemia, restlessness. Management, a small dose of short-acting beta blocker such as esmolol. If hypoglycemia occurs, then we treat it with glucose infusion. Circulatory complication, sinus bradycardia, causes previous history of taking beta blocker, pharyngeal stimulation, residual effects of drugs. Management, oxygen inhalation, intravenous atropine or glycopyrrolate, isoprenaline, temporary pacemaker if complete heart block, cardiopulmonary resuscitation if cardiac arrest. Here is an image of cardiopulmonary resuscitation. Myocardial ischemia, causes hypoxemia, hypotension, hypertension, pre-existing coronary arterial disease, tachycardia. Management, treatment of the cause, sublingual or intravenous glycerol nitrate and cautious use of low molecular weight heparin. Acute pulmonary edema. This is commonly associated with myocardial infarction or ischemia or fluid overload. Management: oxygen inhalation, non-invasive ventilation, diuretic and fluid restriction. Shivering. Causes of shivering are hypothermia, prolonged surgical procedure, cold infusion fluid, subarachnoid block. Management: oxygen inhalation, small dose of cathedral may be useful, can be prevented by using warm cloths or blanket, warm fluid infusion, avoid undue delay in the procedure. Headache, common after subarachnoid block. This is also called post-dural puncture headache. Management: adequate fluid intake, adequate rest, oral caffeine, NSAID, paracetamol, epidural blood patch. Hypoglycemia, commonly occur in diabetic patient having oral hypoglycemic agent or insulin. Features are sweating, restlessness, tachycardia, coma. Hypoglycemia management: intravenous infusion of glucose containing fluid and monitoring of blood sugar level. Hyperglycemia can occur in non-diabetic patient due to inadequate insulin and injudicious infusion of glucose containing fluid. Prolonged coma after surgery may occur. DKA may develop. Hyperglycemia management: as per GKI regimen, 5% or 10% glucose solution co-administered with 0.1 unit per ml soluble insulin solution with appropriate potassium supplement. Intravenous 100 ml per hour. Hourly monitoring of blood glucose. Insulin increment may needed if blood sugar more than 10 millimole per liter. Discharge criteria from post-anesthesia care unit. All patients must be evaluated by anesthesiologist prior to discharge from post-anesthesia care unit. Criteria depends on where the patient is sent, ward, ICU or home. Discharge criteria from post-anesthesia care unit. Easily arousable, full orientation, ability to maintain and protect the airway, stable vital signs for at least 15 to 30 minutes, the ability to call for help if necessary, no obvious surgical complications such active bleeding or severe pain. Discharge criteria from post-anesthesia care unit. Usually we maintain two scoring system for meeting the criteria of discharge for the patient: standard Albert score and modified Albert score. In standard Albert score, we monitor respiration, circulation, consciousness and oxygen saturation. A score of 9 to 10 shows readiness for discharge. The lowest score is 0 to 2. And in modified Albert score, vital signs and activity, assessment of pain, nausea and vomiting, surgical bleeding are monitored. Also, a score of 9 to 10 shows readiness for discharge. Summary and conclusion. Anesthesia is becoming very sophisticated. Post-anesthesia care is an absolutely essential care given by a team of professionals. Anesthesiologists and trained nursing staffs are most important member of post-anesthesia care unit. With a well-organized post-anesthesia care unit, one can prevent a lots of post-operative mortality and morbidity. Thank you everyone. Thanks for your patience and valuable time.